Hello and welcome to day 3 of the 2022 ZERO Prostate Cancer Summit. I'm ZERO CEO Jamie Burst coming to you live just outside of Boston. I hope you found the last 2 days of sessions informative, and you've also been able to check out the bonus on-demand videos in the on-demand section of the platform. One of these years we need to have a bloopers reel on that, so I'll talk to the staff about setting that up. The summit is truly the most impactful event in the movement to end prostate cancer, and it's all because of you and your participation. So I'm grateful that you're here. Once again, I'd like to thank our premier sponsor for the 2022 Prostate Cancer Summit, Pfizer Oncology. At Pfizer Oncology, like at ZERO, they're committed to improving the lives of men living with prostate cancer. And we wouldn't be here together, all in the same room, all in the same virtual room, across the globe without your support. So thank you, Pfizer. Coming up today, it's exciting. We have a lot of terrific sessions later this morning. We're going to hear about health equity in prostate cancer, led by ZERO's Vice President of Health Equity, and my friend Dr. Reggie Tucker-Seeley and Dr. Joseph Osborne at Cornell Medicine will also be presenting about the topic as well. And then Dr. Tom Beer from the University of California, San Francisco is also going to join us, and he's going to talk about PSMA therapeutics, a whole new way to treat prostate cancer that has just emerged in the last couple of years. And if you don't know this, Dr. Beer is known around the world for his research in prostate cancer. He is tremendous. So it's just a gift to have him join us today. And we'll wrap up our Sunday sessions with survivorship and living with prostate cancer, presented by ZERO's own vice chair and my friend, Dr. Alicia Morgans. She's also an oncologist and the medical director of patient survivorship at Dana-Farber Cancer Institute. So thank you to Dr. Morgans for all of her time that she's given to the summit today. And also, she's also the chair of our medical advisory board here at ZERO as well. So she is very busy. I'm not sure if she sleeps. Thank you, Alicia. She'll also be joined by 2 patients who will share their stories about survivorship. And my hope is that you will be inspired from that session. But what a better way to start off a Summit Sunday than when Shelby Mornier, ZERO's Vice President of Patient Programs and Education. Good morning, Shelby. You're all got your first dose of caffeine in, ready to go?
I've gotten 2 doses. Thank you. Good morning, everyone. So I'm ready to go. 2 doses in, a little breakfast. I hope everyone got a lot of rest last night and is ready to go this morning. We have a jam-packed day. We're really excited about all of our presenters. Thanks again for everyone who is participating in the chat and the forum. So many fun, engaging comments and questions and love and support. It's just so fun to see.
Yeah, it's I've been looking on too. It's just great to see everybody connect through there. And the topics we have scheduled for today are critically important to patients, as we were just alluding to, as well as survivors and doctors. And I know you're beginning this morning with Immuno-Oncology and personalized medicine in prostate cancer, which is a key area in advancing survivorship of prostate cancer. So I don't want to take up any more time. I'm going to bounce it over to you, Shelby, and let's kick it off. Let's get things started.
All right. Thanks, Jamie. We'll see you a little bit later today.
Bye, Shelby.
All right. So as Jamie said, we're going to kick things off this morning with an amazing presentation on immuno-oncology and personalized medicine and prostate cancer. We talked a lot yesterday about the fact that there is no blanket treatment plan for prostate cancer. So we're thrilled to have this personalized medicine talk. Our speaker and expert on this subject is no stranger to ZERO or the summit. We are welcomed again by Dr. Michael Groaning of Amgen. Again, he was with us last year to talk about groundbreaking BITE technology, and it was amazing. It was a very, very interesting presentation last year. So much good feedback about the exciting topic. So be sure, if you didn't participate last year, or you're new to ZERO, or you missed it, or you want to refresh, check that out. It's on ZERO's YouTube channel. And if I'm not mistaken, Dr. Groaning, this is going to be a little bit of a deeper dive, if I'm understanding correctly. So we're thrilled to have you, Dr. Groaning.
I appreciate it. And that's a great introduction, Shelby. And yeah, this will be a continuation of last year's presentation. So last year, just as a quick reminder before you get to go into YouTube and do that deep dive, it was just basically a summary of the platform as a whole. So as Shelby mentioned, this is a new technology where we're looking at targeted immuno-oncology, type of therapies. So specifically, what we covered last year was the BITE platform. And the BITE terminology is an acronym for a bispecific T-cell engager. So just quickly what that is, it's a way of engaging the patient's immune system to, kind of help it do its job at attacking the cancer cells. Because at least on the topic I'm going to cover today with prostate cancer, that's traditionally known as kind of a cold tumor. It's something that immunologically is not something that you kind of go through that normal traditional immune response. So this type of therapy is meant to kind of create that synapse, that gap between the T cell and the cancer cell to get the immune system to, to attack and get rid of the cancer. So what we're going to talk about today, though, is specifically the portfolio at Amgen of this technology. So as you can see from the title slide, it's advancing prostate cancer treatment with these T-cell engagers and some new targets. As you heard, the chat between, with Shelby earlier was, some of the work with PSMA. So that's probably the most common one we've heard about lately, especially with the with radioligand therapy. As we mentioned last year when I was here, I just freshly moved to Amgen. I had come from Novartis and the PSMA 617 space in the VISION study. So very familiar with PSMA targeted radioligand therapy. And what excited me about Amgen was kind of that breadth of the portfolio where it's a new technology and there are multiple targets that we're looking at. So that'll be also a topic that we're going to be addressing today. So just to go over those objectives again, just want to do a quick overview of the unmet need in prostate cancer, especially in the metastatic castration-resistant setting, because that's the one of the highest unmet need and the biggest concern that we have. And then we're going to review the role of immunotherapies. And again, like I mentioned, traditionally these things are seen as, cold tumors. So how can we engage, T cells and the immune response in order to treat prostate cancer? And then lastly, more of a deeper dive, like I mentioned, we have more than just PSMA targeted therapies. STEAP1 is another therapy or therapeutic target, which may not be that commonplace for folks, and DLL3, and that's for the more advanced small cell-like prostate cancer. So just a quick summary. We know that prostate cancer is a significant cause of cancer-related death in men. As you can see from this slide, 1.4 million new patient diagnosed and 375 estimated deaths due to prostate cancer worldwide. So this is a huge area that we try to focus on as it's, large unmet need. And just kind of shifting our gaze downward, when it's caught early, the 5-year survival rate for localized or regional disease is quite good. But once it gets metastatic and you have distant disease, then that survival rate does drop off quite a bit. So that's where we're trying to provide, some life prolonging therapies and doing what we can to improve the quality of life, introduce new tools into that armamentarium that the oncology world has to treat prostate cancer. And let me get the next slide. So what we want to do here, so immunotherapy utilizes the patient's own immune system to fight cancer. So this is actually something that's become quite successful in other types of cancers. With lung cancer, for example, a lot of times you'll see commercials where they talk about, the non-chemotherapy. And, what they're really targeting there is just, activating the immune system to do what people think it does, and getting rid of foreign cells or just malignant cells where, it leads to metastatic disease or just poor outcomes with the patients. So what we want to do, if we start looking at the top left and work our way around, so we're targeting tumor-associated antigens and, includes this specific immune response. And when I say targeting tumor-associated antigens, when I was saying that the tumors are considered cold tumors, that's because, prostate cancer oftentimes is thought of as cold because it doesn't express what's considered a MHC. It's a major histocompatibility complex. That's the part of the cell that the immune system recognizes. So what we try to do is target that by creating a molecule that'll recognize some other type of antigen on the cancer cell that then we could then attach on the other end of the molecule to the T cell to bring those two together. So that's what it means when we're looking at targeting tumor-associated antigens. And then just moving down to the lower left, disruption of the inhibitory signaling pathways, and trying to restore that immune system. Again, when we, especially the last couple of years with COVID, we hear about this, escape mechanism that viruses and cancer cells might even have. So what we're trying to do is restore the immune system by bringing those T cells back to the tumor through some other type of mechanism to sustain that anti-tumor activity. And then if we move to the bottom right, modulating the tumor microenvironment to enhance engagement of the immune system. The way we can modulate that tumor microenvironment, again, if there's some type of expression of an antigen that we know, that modulation of that microenvironment, whether we're talking about PSMA or STEAP1, DLL3, any of those other targets, if we can, modify that, we bring in T cells, let them proliferate, and just basically put on a full assault on the cancer. That's what we're hoping to do with this type of immunotherapy and the advantages it might have. And then finishing off at the top right, stimulating the patient's own immune response. What we try to do is, again, if you bring them together and you have these memory cells that can then recognize later on, even without the assistance of a bispecific, then they can come back and attack that antigen that we mentioned on the top left over there. So that's kind of the concept behind, utilizing the patient's own immune system to fight cancer, just helping to bring those two together to, kind of start that process that otherwise may not occur. And immunotherapy options, they are limited for patients at the moment for a few reasons. One of the ways we can, identify, I guess, some of these limitations is that the adoption of the therapy in the clinical practice is complicated when we think about just the evolution of what goes on with T cells and T cell engagers, or something that, we're trying to use to improve upon that. So the complex collection administration process, when we think of other types of cancers where they're doing CAR T therapy, when you hear about CAR Ts, that's something where they have to harvest the cells from the patient and then modify them and then reintroduce them. And that makes it somewhat complicated, but it's very effective. In fact, in the last month or two, there was some news at the original CAR T therapy that was done on some patients 10 years ago. They were still detecting those CAR Ts in the patient. So we're not trying to do that necessarily with bispecifics, because we're not modifying someone's T cells. But what we are trying to do is simplify the process. So it's a similar idea where we're trying to engage the T cells in the natural immune system of the patient, but trying to do it in an off-the-shelf manner. And that's, our way of trying to improve these limitations that currently exist. And then moving over to the right a little bit, where it says significant proportions of the patients aren't eligible. Now, again, thinking about prostate cancer patients, if you look at the NCCN guidelines and the use of pembrolizumab, for example, that's something that's in there, but it's restricted for patients that have certain biomarkers that are identified. So if they're MSI high, so this is this kind of microsatellite instability, or if they have a different type of TMB status. So you're looking for very specific patients. And unfortunately for those, at least in this kind of traditional immune response type of environment, that's limited to, a few percent. And then last, if we look over at the right, the limited clinical benefit with therapies that target only a subset of patients. Again, we want to be able to make this as broadly accessible to patients as possible. So when we look at what's traditionally available, it does have its limits. So what we're trying to do is, expand the access to patients to these types of therapies. So next, T-cell engagers are immunotherapies that are being investigated across multiple cancer types. So again, what we try to do here, and you can see from some of the the illustrations here on the right side or the right panel of this slide, where we're looking at the BiTE molecule. You see the blue portion and then kind of the magenta portion there. So what that represents are these two different parts of the molecule. The one side engages the T cell, the other side engages the cancer cell. And then moving down to the next one below, the HLE BiTE, what that HLE stands for is that half-life extended molecule. So that's something where we just try to increase its circulation time in the body in order to make the administration and dosing a little bit more patient-friendly, for example. And then moving down a little bit, you see what we call the XmAb bispecific antibody. So the XmAb, what that acronym stands for, it's a partnership we have with Xencor is the name of the company. So the X would be for the Xencor monoclonal antibody that's a bispecific antibody. And then lastly, when you look at the last one, you see the UniAb bispecific T-cell engager. This is another platform, that Amgen's working on through the acquisition of TenneoBio. And that's something we're excited about, because what's different about this molecule, and we'll get into that a little bit later, has to do with how it is actually binding to the T cell, the CD3 portion. It's a little bit different than the other traditional bispecifics or the BiTE molecules in the way that it's a little more loosely bound. And it's one of the side effects from T cell type of therapies is the cytokine release syndrome. It's something that occurs, it's something that's expected, but when it gets too much, then that can be kind of an issue that we need to try to mitigate. But with this type of platform, what it does is the way it binds seems to mitigate, that amount of CRS that occurs. So these are the three targets that I was talking about as far as what we have in our portfolio. So starting on the left, this one's very familiar, like I said, especially with radioligand therapies. PSMA is a prostate-specific membrane antigen, highly expressed in prostate cancer, but it's also expressed in other cancers. So one of the things that you'll see, I'm not sure, Shelby, if you had presentations on the imaging or any of the cool technologies with that, but when you look at the imaging from PSMA PET, you'll even see things light up in people's salivary glands, for example, and other locations. So it's not just something that's expressed in prostate cancer, even though it's a prostate-specific membrane antigen. So things like ACC, it's a rare type of cancer, but it's one where PSMA can be used for that as well. And then moving over to the right, we'll see STEAP1. So that's another acronym that stands for 6-transmembrane epithelial antigen of prostate. And this one's highly expressed in prostate cancer, but it's also expressed in other cancers. So for example, we're looking at Ewing sarcoma with targeted STEAP1 therapies. And then lastly, on the right side, we see the delta-like ligand 3, which is DLL3. And this is one that is upregulated on the surface of high-grade neuroendocrine type of tumors, including neuroendocrine prostate cancer. But again, think of it more around, small cell type of cancers. At least at Amgen, we have a program that's also focused on the thoracic space. So small cell lung cancer is one where DLL3 is a great candidate. So one of the great things about the portfolio that we're showing here, at least with the targets, is that we're trying to take a holistic approach to prostate cancer as a disease and helping the patient along their entire journey. So for example, PSMA is expressed at various levels. You'll see that there are studies where they're even looking at hormone-sensitive prostate or hormone-sensitive prostate cancer, castration-resistant prostate cancer. So we're looking at the whole gambit there. With STEAP1, that's also something that's expressed even in the hormone-sensitive setting, castration-resistant setting. Now, with DLL3, since it's for neuroendocrine prostate cancer or small cell like prostate cancer, it's typically seen as kind of a treatment emergent aggressive variant of MCRPC. So this is something that can be kind of reserved for that late stage patient. Although there are some patients that do have de novo neuroendocrine prostate cancer, that's a very small population. So we kind of envision this as something that would be used for patients later in their journey, where it's more aggressive end stage type of prostate cancer. So these are the different targets that we're looking at with these different immunotherapies that they were mentioning. So focusing on each one of those targets, take a little bit of time for that. So PSMA, especially with the imaging and now with the success of the VISION study and what everyone's expecting to be an approval here shortly, PSMA has become a clinically validated therapeutic target, and it's highly expressed in prostate cancer. Again, if we look at the results from the VISION study, this is something that was, the positivity rate in those patients was in the high 80s. So you can see from the second bullet point here, something that, we expect in greater than 85% of prostate cancer cells being PSMA positive. So this is something that's very prevalent. So it makes it a great target. When we talked earlier about some of the shortcomings in the immunotherapies, is that, if it's looking for a specific subset of patients, you're only helping a small percentage. When we look at, how prevalent PSMA expression is, we can help more and more patients that way. These PSMA expression levels do seem to change longitudinally, so meaning over time, and it can start to increase, and then at some point, when they're very late stage, that expression level can change and drop depending on the prior therapies, and then that's when, like I mentioned, we would like to have that other option of a DLL3 type of target, for example. So one of the things we could look at here, as you can see in the fourth bullet, is that we can aid in diagnosis of patients because there are a couple approved PSMA PET agents that are out there. So, we saw the recent approvals of gallium-based PSMA imaging with F-18-based with PYL. So there are a lot of options here, and they're being used earlier and earlier on. Also, the NCCN guidelines were updated recently to include PSMA PET imaging as an option, to look at assessing patients and helping with the patient management decisions. And then lastly, on that last bullet point, you can see that, like I said, PSMA is recognized as clinically validated, again, through the success of the VISION study. And I think everyone kind of felt that that was a great target, especially looking at the various imaging studies and how that correlated to outcomes. So this is a target, like I said, that we're very excited about. We have two active programs looking at that, one with AMG 160 and one with now what's called AMG 340. We'll talk a little bit about that one later. That one is the one that is related to the UniAb target that we talked about. So next, going down a little bit deeper, looking at the STEAP1 as a potential therapeutic target. So again, this is one that's also highly expressed. It's localized in the plasma membrane of epithelial cells, and it's located at the cell-cell junctions and primarily expressed in prostate tissue. Having said that, though, like I mentioned, this is also expressed in Ewing sarcoma. So that's something that we're also looking at there. So the other good thing with this is that the expression is low or absent in normal tissue. So what this helps us do is, we always like to have, precision targeted therapies. So with these, having it expressed primarily in prostate cancer and a few other normal tissues kind of helps us with those off-target toxicities that could occur. And then lastly, this is one that's also overexpressed in a large percentage of prostate cancer. And that's, again, one of the advantages of something like this, because we don't have to worry about only a small percentage of patients having access or being eligible for something like this. If they express that target, then they would be good candidates for that. And it's great that, the prevalence is so high where a lot of patients would have access. And the next, looking a little more closely at the DLL3 target. So here, like I said, it's an inhibitory notch ligand that doesn't mean much to the non-science folks like myself and maybe some of the physicians on the call, but it's just a great target for the late-stage prostate cancer patients. It's upregulated on the surface of small cell lung cancer. Again, that was the one other program that I mentioned that we have on the thoracic side. So we can think of, instead of just thinking of neuroendocrine tumors, think of it more small cell-like. Again, that's why when I mentioned neuroendocrine prostate cancer, think of it more as this treatment-emergent small cell-like set of patients. And then in the study that we've done, 423 patients with prostate cancer, DLL3 was expressed in 77%, with 64% of the cancer cells expressing DLL3 specifically. And like I said, the advantage of that is that, we're looking for targets where you don't really limit the access to the therapy, where it's only a small percentage that might fit into that category. So as you can see, these three targets that, make up the portfolio we have, at least in our prostate cancer programs, they have great prevalence in prostate cancer. That way, like I said, we could hopefully have access to these therapies to a lot of patients. So hopefully what this illustrates is that, Amgen is committed to developing these novel targeted immunotherapies to address these needs for the prostate cancer patients. So like I mentioned, we're really focused on the unmet need of the metastatic prostate cancer patients, because again, once it goes outside that local regional, stage and it goes into distant metastases, the outcomes are very poor. So we really want to focus on that space for the patients, and hopefully improving their quality of life. That's one of the things that we definitely are focused on with the development of these products. And then Amgen, if you look at the center box there, is focusing on leading edge of immunotherapy development in prostate cancer. So we do have experience with these bispecifics in hematologic malignancies, and we're really making a lot of effort into making that transition to solid tumors, specifically to prostate cancer, and being the leaders in that space as well. And then lastly, if we look at the far right, we're investigating various modalities, designed to engage the patient's own immune system. And what we're hoping to do, again, is to leverage the patient's immune system with these different targets so that, we can help with these outcomes and provide more tools for the, for the physicians to use when they're trying to make the, best decisions for the patient. So lastly, I just want to summarize with, mentioning, how prostate cancer is a significant cause of cancer-related deaths in men worldwide. Despite recent advances in various solid tumors, currently approved immunotherapies only work on a subset of patients with prostate cancer and have oftentimes, had limited clinical benefit. And then we talked about the T-cell engagers and how they might represent a new class of immunotherapies designed to engage the patient's own immune system, but doing it in a way where, like I say, you kind of help create that synapse between the two cells to help them, facilitate the job that they naturally want to do. And then lastly, going over the various targets we have in the portfolio. PSMA, which is a well-established one that I think everyone is aware of. And what we're hoping to do is kind of raise awareness to the general community about these other two. So STEAP1, which is one that kind of runs parallel to PSMA as far as the patients that make up that group that might benefit. And then DLL3, when you're running into a very advanced, aggressive disease, late stage, when there aren't very many options, we want to hopefully provide another option for those patients that might express DLL3 in their disease. So hopefully that gave a good summary with what we have. And hopefully, Shelby, if there's any questions, I'd love to take some time to address any.
Yeah, thanks, Dr. Groaning. Yeah, that was a great presentation. Thank you for touching on all of this exciting technology. We do have a couple of questions that have come in, and just a reminder to those listening, if you have questions, please drop those into the chat, and our team is feeding them over to us on the back end. So don't be shy. So we do have a couple of questions, Dr. Groaning. The first one is kind of just back to your summary slide a little bit. And originally, or not originally, I guess a few moments ago, you talked about how we seem to be hopefully fairly close to an approval for the PSMA target, but how far out are we for the STEAP1 and the DLL3?
So STEAP1, there aren't a lot of advanced programs going on with that. So we're probably still 3 to 4 years away from something with STEAP1 having broad access. The clinical trials are ramping up, so there might be access at least through a clinical trial, in the next couple of years. But as far as an approval, those are still early on. PSMA is a very busy space, as you can imagine. With the radioligand therapies, there's multiple versions of those or variants of those that are out there, not just Novartis, but other companies. Mm-hmm. And then, there's other PSMA targeted bispecifics. So when you look at, the other 2 targets in the portfolio, that's just something that, will take some time, but that space is a little more open. I hope that answers the question.
Yeah, it definitely does. Do we expect those terms to be kind of household names like we hear, like PSMA? I think we all agree that if you're in the prostate cancer space, PSMA is becoming more of that like household term. Do we expect that for the other 2 down the road?
I think that they'll become much more commonplace. One of the things that really helped PSMA, it wasn't even just the therapies necessarily. Although those make a big difference because, we have the VISION study that helps as far as like validate that target, at least in the radioligand space. But the imaging has been going on for quite some time. And I think that helps as well. So there was a well-established imaging agent out there for PSMA. In fact, those initial approvals for things like PYL, PSMA-11 were for that BCR staging indication. So it's very early on. So there wasn't really a therapy associated with it. It was seen as kind of like a next generation imaging agent that did help with patient management decisions. Now, STEAP1 and DLL3 haven't had that just yet. So having an imaging agent, I think, helps, because when someone sees, the target expressed a lot. And that's one of the things, at least from a patient perspective, we've always heard, it's kind of like the old saying, a picture's worth 1,000 words. If you can see, an image of your disease and then you take some therapy and then you see that same, next generation imaging and you see the disease go away, that makes a huge impact. You can see the progress. It's, almost like watching your PSA values, dropping, which everyone's very acutely aware of. I think PSMA imaging is in that same kind of space, at least from a patient perspective. Now, if STEAP1 and DLL3 get to that point where the imaging becomes more and more accessible and common, it'll become a little bit easier. But I think if the therapies are successful, even without an imaging agent that goes with it, then that'll help make it more commonplace. PSMA is kind of it's been around for quite a while, so it's had a lot of history. Imaging helped quite a bit. So if we apply those same timelines, I think to STEAP1 and DLL3, it'll be some time away, but hopefully they'll both get there.
Yeah, absolutely. Very, very exciting. We have a couple of more questions. One is, it says, do PSMA levels change based on the patient's age or aggressiveness of the prostate cancer?
So age doesn't necessarily have much to do with how it's expressed. There are a lot of factors that could affect PSMA expression. There's been studies that have shown that if you have, let's say, like abiraterone or enzalutamide, so if you think of this AR signaling inhibitor or AR axis type of therapies, depending on the stage of disease, those are known to upregulate PSMA expression. And some other stages of disease, if you have an ADT or androgen deprivation therapy, there's been some studies that suggest that it downregulates PSMA expression. So depending on prior therapies, that can alter the expression level. What can happen, though, depending on how advanced someone's disease is you can lose expression of PSMA. And again, that's where, like I mentioned, the DLL3 target becomes attractive because now it gets into that small cell type of disease, and PSMA expression then decreases quite a bit. Hope that answers that question for them.
Yeah, thank you. I have another question here, Dr. Groaning, that asks, this patient is wondering why the application is currently limited to ADT-resistant later stage cancer, and just really an inquiry and why not try this before the metastases.
So that's a really good question. And I think oftentimes, at least in drug development, we try to think of ways to, how do we best bring a drug into clinical practice? So a lot of times what people do is, or what companies like to do, is you'll take it in this late stage setting, because when you're trying to introduce a new therapy to a patient, typically what's done is that if there are other life-prolonging therapies that are available, those are chosen first. So, until you prove that your therapy is something that's life-prolonging, is when it's still experimental and investigational, it's not really an ethical practice to try to go too early. In fact, part of the process of starting a clinical trial is you have to have an independent review board, look at the ethical aspects or safety aspects of a study. And if there's not really any proven benefit and you do that in lieu of something that could be, life prolonging, it wouldn't really be fair to the patient to do that. So, why we don't immediately go into a patient population in the, prior to ADT, it's primarily for those reasons. You want to go into the late stage, unmet need setting where the patient doesn't really have a lot of options, and you're exploring to see if this could be a valid option for them. And if you can prove in that setting, when they have no other options, that it is effective, then you can start to move, into these other settings, because you have demonstrated that it could be life prolonging. So that's the main reason why, we don't immediately go into, the pre-ADT setting when you explore new therapies like this.
Right. Yeah, that makes sense. Thank you. We have a question that came in. It's a little bit specific, so I'm going to try to remove some of the specifics for you, as I know you can't. Yeah, you're very welcome. But I'll do my best here. So with prior, a couple of treatments prior, but steady PSA, PSA levels holding steady, but currently on a couple of different treatments. Would there be any clinical benefit to including this in this person's treatment at this time?
So it really kind of depends. That's a conversation you should have with your physician. There are clinical trials that are going on, and, we try to be specific with the patient populations in the clinical trials. And if you look on clinicaltrials.gov, you'll see inclusion-exclusion criteria. So when you look at those, it'll kind of define the patient population that, a company might be interested in seeing if there's any benefit of this therapy. So, if you fit some of those inclusion and exclusion criteria, it's worth, having that conversation with your physician. But, that should be the first step. Talk to your oncologist or urologist, depending on where you're at in your patient journey, and, see what they think. But you can always ask, a physician, are you aware of this type of therapy? And, and just ask them questions about it. Hope that helps, but I can't give a specific example. Yeah, it's just, yeah.
I know. No, that's it. And you bring up a great point just about clinical trials in general and treatment options in general, and having those conversations with your provider is so important. And clinicaltrials.gov is great. You can really kind of filter by what you're looking for. We also have a clinical trial finder on our website that's user friendly. We want to offer patients both because of different preferences that people might have. We do have a question that came in about side effects. So can you share a little bit about the side effects that this treatment might have compared to maybe surgery, radiation, hormone therapy?
Yeah, so I mean, these are all at a pretty early stage. So, we don't really have enough data to give specific side effects. But since they are, T-cell engagers, the one that's probably the most common would be cytokine release syndrome. And it's important to, especially in the last couple of years with all the information around COVID, differentiating between cytokine storm and cytokine release syndrome. Perhaps people on this call or in the meeting have heard of cytokine storm and some of the issues around COVID where that became, a point of discussion. So there's a big difference between that and cytokine release syndrome. So the way T cells work is, they kind of activate that immune response. That immune response leads to the release of cytokines in your body. And that's a very natural thing. And that kind of propagates, proliferation or increase of your T cells, and they can attack the cancer. But what that also does, it can cause kind of an immune response in your system where you can have things like, an increased fever, or you can have things where you can have kind of hypotension as another side effect of cytokine release syndrome. There's also, little bits of hypoxia that can occur. And those things are treatable, again, depending on how severe it is. And that's probably the most common side effect that can happen with T-cell engagers in general. That's something that, that we try to mitigate and minimize. There's preventative ways, that you could, or preventative means you could take to help minimize that. But for this whole class of molecules, that's probably the biggest side effect. And it varies on when it occurs. When you think of T cells in the CAR T space, the onset of those things can take days. One of the interesting things with these bispecifics, it's on the order of hours. So it's usually quicker as far as like the kinetics of that side effect. And it usually doesn't last very long. So those are just kind of high-level, broad ways of describing the side effects. And like I said, it's still too early to give kind of a specific list at the moment.
Okay. Yeah, no, that makes sense. But we brought up COVID, and naturally we do have a question not specific to COVID. I think you're going to be just fine answering this one. But I think in general, I think some people do know what cytokine release syndrome is, but could you explain just what that is and what might occur with that syndrome?
Well, so it's just where it gets out of control. So it's something where, with cytokine storm, it's almost just, if you think about when these cytokines are released, and if it's just, they just start to increase to a point where, it becomes detrimental. So when you have cytokine storm, that was kind of the end stage with COVID, essentially. There are ways where people try to, intervene. But that's something where you just have like an uncontrolled release of the cytokines. We could give like a list of what the cytokines are specifically, but basically what it is, it's kind of an immune response that you have. We'll just leave it at a high level like that, unless there's a follow-up question.
Well, it looks like there might be, but it's not being fed to me yet. But yeah, I think that works. But we really appreciate your time, Dr. Groaning. So appreciative of you, of Amgen's participation and support in our Prostate Cancer Summit. Thank you to your commitment, to Amgen's commitment of improving the lives of prostate cancer patients, and just so honored that you were here with us again on this fine Sunday.
Yeah, no, I appreciate it, and happy to answer any follow-up questions if you need to forward any on.
Okay. Yeah. Thank you. Yeah, we might, they are, I think, a lot to digest. So
Yeah.
we do get questions. And then of course the recordings will be posted. So we would appreciate that. And we can help pass those along to participants who have those questions.
Awesome.
All right. Well, thank you, Dr. Groaning. And to our attendees, we'll take a short break. And at the top of the hour, we will be back. Thanks, everyone. See you soon.
Thanks.